Welcome back to Therani, I'm Joe B. Today I'll show you how to correct a unilateral sacral flexion. Let's dive in. Unilateral sacral flexion is when the lateral border of sacrum, in this case the right side, gets stuck forward or anteriorly. To treat a unilaterally flexed sacrum in this animation, we'll assume that it's the left side that's unilaterally flexed. Position the patient in left side lying with the therapist in front of the patient. The therapist flexes the patient's hip and knees until the lumbosacral joint is in neutral position. The therapist pulls the patient's left arm towards the left hip to cause left sacral side bending and right rotation for the L5, which results to left unilateral sacral extension. L5 is monitored by the right hand, while the pisiform bone of the left hand is placed on the left ILA, with force parallel to the table to provide or cause sacral extension. The pressure is held for 30 seconds for 3 to 5 reps. Prone toe outs can be provided to the patient. Hip external rotation strengthening as well as stretching towards hip external rotation can also be provided. The assessment for unilateral sacral flexion requires two bony landmarks to palpate: the sacral base and the inferior lateral angles. To palpate the sacral bases, patient position is in erect, relaxed, short sitting with hands across the shoulders. The therapist will be behind the patient with the first web space of both hands palpating the iliac crest first. From there, the thumbs will slide down to palpate the posterior superior iliac spine, or the PSIS. Then the thumbs will go up and medially by 1 finger breadth to arrive at the sacral basis. The patient is then asked to slouch the low back, which results to sacral extension and lumbar flexion. Normal findings are that the sacral basis move posteriorly or becomes shallow. Abnormal findings are that the right sacral base stays deep or anterior. To palpate the inferior lateral angles, or ILAs, the patient and therapist position will be the same as with the palpation of the sacral basis. Both thumbs will slide down from the iliac crest to the PSIS. Then the dominant thumb palpates the S2 spinous process, then S3, and then S4. Once S4 is reached, the thumbs will go 2 to 3 finger breadths inferiorly and laterally to arrive at the ILAs. The patient is then asked to slouch the low back, which results to sacral extension and lumbar flexion. Normal findings are that the ILAs move anteriorly or becomes deep under your palpating thumbs. Abnormal findings are that the right ILA stays less prominent or becomes deep than the left instead of sinking backward. The cause of this can be due to repetitive toe-in walking or trauma like a vehicular accident. This can result to hip internal rotation, resulting to iliac inflare that stretches or sprains the anterior sacroiliac ligaments on that side, causing the unilateral sacral flexion. In addition, there can also be opposite unilateral sacral extension. Unilateral sacral flexion can bring about one-sided sacroiliac joint pain, in this case, the right side, above the ischial tuberosity but below the belt line. There will also be a toe-in and limping gait pattern on that side. More importantly, for extreme cases, the buttock will be less prominent on the painful right side during postural inspection. Want to correct another sacral dysfunction? Watch this next video. Thank you so much. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.